Hey guys, welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a difficult question that you don't know the answer to, we feel that you'll be able to fall back on these first principles to formulate a decent answer and reason your way out of trouble. On this episode, Jason will be taking us through Haemolytic Disease of the newborn. Take it away, Jason.
Yes, thank you. So, welcome to 1pm. Today we'll be talking about Haemolytic Disease of the fetus and newborn, which is shortened as HDFN, which is not really that short. But anyway, we've got a special guest today. Do you want to introduce yourself?
Hello, everyone.
Thank you. Very distinguishable.
I'm Josh.
Josh, yeah. So we've got Josh, another MD3 student.
Thanks for having me on.
Who's kindly joined us today. So yeah, Josh and Aiden haven't done ONG, but JT and Dan have, which is going to be interesting.
Briefly,
you've done the full rotation, man. You should know what I'm going to be talking about. But anyway, we're going to start today by going through some of the first principles of haemolytic disease.
Love those first principles.
Yeah. So the first principle revolves around the fetal maternal blood supply. So this is a 50-50 guess. In normal physiology, does the maternal and fetal blood physically mix with each other?
No.
I reckon.
Anyone?
I reckon.
Anyone
Nice.
else?
I'm going to say no.
I'm going to say no, only because these guys said no.
Yeah,
should,
well,
right?
you are right, okay? Maternal and fetal blood do not mix. That's normal physiology, okay? So how does oxygen transfer from maternal red blood cells to the fetal red blood cells?
Diffusion.
Yeah, but what causes the oxygen to diffuse from the maternal red blood cell to the fetal red blood cell?
I'd say it's down a concentration gradient, so
Yeah.
from high oxygen to a low oxygen area.
Yeah, but the fetal red blood cells also have some key features which differentiate it from adult red blood cells. So the hemoglobin, fetal red blood cells, have higher affinity for oxygen than the maternal red blood cells. And there's also more hemoglobin per red blood cell in fetal red blood cell compared with maternal red blood cells. Does that make sense?
Yep.
Next first principle, this is everyone's favourite topic, immunology, okay?
Gross.
So can someone please describe to me what an antigen is?
I think Josh, you
Bugger off. An antigen. Oh, in my very basic understanding.
Hey, we're keeping it first principles, man.
First principles. A small protein structure that the immune system in the body recognizes and can target.
Yeah.
Okay.
Mate,
There you go.
why
There you go. Yeah. There you go.
yourself?
Back yourself, Josh. Come on.
So the definition I had was, a substance that triggers an immunological response and reacts to antigen. Yeah. It triggers an immunological response.
Wait, do you know what it is?
I'm reading off this, man.
I think Josh's definition is
Okay.
clearer.
Anyway, next definition, antibody.
All right, Daniel.
Daniel,
You look like you know what it
you
is.
love your immunology,
Yeah.
don't you?
Yeah. A immunoglobulin, or a structure that the body produces in response to an antigen.
Perfect. Don't even have to change that. See?
Whoa.
So antigen, antibody, done. Okay. So this is important because I'm going to talk about this concept called maternal alloimmunization. Can't pronounce anything today. Maternal alloimmunization. Okay. So this refers to the induction of immunity in response to foreign antigens encountered through exposure to cells or tissues from a genetically different person. So the reason why I bring this up because essentially the baby is genetically different from the mother, even though it shares some genetics with the mother. And now all this fetal maternal blood supply, antigen versus antibody, brings me to rhesus factor. Okay? Does anyone know what that is?
It's named after rhesus monkeys, I believe, and it's the antigen on the red blood cell that you can either have a positive or negative. So when you donate blood, or when you know your blood type, it's either A positive or A negative.
Yeah.
I think the positive negative refers to whether you have the presence of the rhesus antigen on your blood cells.
Yeah, so the red blood cell has many different antigens and rhesus is one of them. And as JT explained, there's an ABO blood group system which gives you A, AB or O. And then the positive at the end refers to whether you're rhesus positive or rhesus negative.
Can I just ask a really quick dumb question?
No.
For the
We love
A,
it.
B, O blood group, just to remind me, is it like you either have A antigen, B antigen, both AB, and then for O, is that a different or is that the absence of?
So A, if you're blood group A, means you've got the A antigen.
Yep.
If you're blood group B, you've got the B antigen. O means you do not have any of those
Okay,
antigens.
cool.
That's my understanding.
Yeah,
And
pretty
that's why you can become a universal donor when you have O negative, because you don't have any of those antibodies in your blood.
No antigens. So you if
No,
you're-
you don't have the antibodies against the antigens, so therefore your blood can go into anyone else's blood without attacking there.
I think you're not quite. Yeah.
Yeah. So it's if somebody has only B antigen in their blood and you put their blood in somebody who has only A, the person who has A, that person will develop antibodies in response to the B antigen, and A person's antibodies will attack the B person's red blood cells and cause the reaction.
Oh, okay.
Yeah.
But then that's why O's got none of the antigens.
So O isn't going to
So then
induce the immune
person,
response.
if you donate blood to that person, they're not going to attack it at
So
all.
if the O person can donate to other people because it won't induce an immune response in those
From
people.
the other people.
Yeah.
a classic JT with the distraction and the sidetrack.
You love it.
So anyway, so if you're rhesus positive, means that you have the rhesus antigen on your red blood cell. Rhesus negative, you do not have the rhesus antigen on your red blood cell. Does that make sense?
Yep.
Okay, so there are a variety of scenarios I want you to think about. Okay, so if the mother is rhesus negative and the fetus is rhesus positive, what does that mean?
It means if the mother encounters the fetal blood, the mother will develop antibodies to RH. Yeah.
Exactly. So that's an important thing to realize. Yeah. So if the mother is rhesus negative and the fetus is rhesus positive, what can happen is that if there is somehow a maternal exposure to the fetal blood, which is called a sensitizing event, that can lead to the production of maternal antibodies against the rhesus antigen in the fetal red blood cells. Okay? And then what happens in a subsequent pregnancy with another rhesus positive baby, there's a rapid production of maternal antibodies to the fetal red blood cells, which have the rhesus antigen. That leads to hemolysis of fetal red blood cells, and then that finally leads to Haemolytic disease of the fetus and newborn. Okay?
So just a question. So that process only works because the mother's antibodies can cross into the fetus. Yep.
And you brought up a good point. So what happens is that when a sensitizing event occurs, maternal IgM is produced against the rhesus antigen, and that cannot cross the placenta. But over time, the IgM undergoes seroconversion to IgG, which can cross the placenta, leading to destruction of fetal red blood cells. Okay, so that's the key example. But what happens in the other scenarios if a mother is rhesus negative and the fetus is rhesus negative?
Nothing,
Nothing.
I assume.
Hey,
No.
just what happens if the mother is rhesus positive and the fetus is rhesus positive?
Nothing.
Nothing.
Yeah.
What happens if the mother is rhesus positive and the fetus is rhesus negative?
The
Nothing.
baby will
Oh.
become rhesus
Yeah.
positive?
No, it's nothing.
Nothing.
No.
No.
Trick question there.
It's
No,
a trick
nothing.
question.
So does the
Can they?
baby-
Can't they?
No.
So in the same
As-
way the
as in
mother
what do you mean?
produces-
Wait, just wanted to. Well,
Oh, sorry.
in the way the mother produces these antibodies,
Can't the baby do so too?
yeah.
yeah, but if you think a little baby's not going to produce that many antibodies
Okay.
to like.
Because baby has an
Yeah.
immature immune system.
Yeah.
Yeah. So, Josh, what is the clinically important scenario?
If you have a rhesus negative mother
Yeah.
and a rhesus positive baby
Yes. Cool. That's
On
all.
the second pregnancy.
following a sensitizing event.
Yes.
Yes.
Cool.
Okay. And it's just important to note that rhesus incompatibility is not the only cause of hemolytic disease, okay? So rhesus disease is the classic example of it, but there are other causes. So other causes include other red blood cell antigens such as Kell, Duffy, Lewis, and the ABO system itself, okay?
If you donate at Red Cross, you can actually ask for your blood group, and then I asked for mine, and they actually gave a whole
Oh, like the
list.
full Kell, Duffy. And,
Yeah.
Oh,
And then they
really?
said I was a rare blood group donor, so I should donate my blood even more
Yeah.
often. But it's whatever. So fun
I don't have
fact.
time for that.
No. They don't know,
Swear.
but I just want my picture on
Do
the
you-
wall of fame or whatever.
Do you know what's depressing? So I've got really shitty veins, okay? Terrible. And my blood group is AB positive. So that makes me the universal plasma donor
Yeah.
because my plasma doesn't contain any antibodies. That's the way I understand it.
Yeah. Okay.
The only thing is, for plasma, you need really good veins because they put the fluid back into you. So every time I go to the front desk, they're like, "Oh, we'd love for you to donate plasma," and then they finally like do my regular like blood donation. They're like, "You should not do plasma." But the cycle repeats. They go to the front desk, like, "We're really desperate for plasma. Like, give me like the info brochure." It's like, "You haven't seen my veins, mate." Okay.
You're doing it disservice.
So do you try and donate plasma? Or
No,
you just-
no, they
you
like
don't?
straight out just refuse.
Yeah.
Okay.
As in, like, both arms, your veins are just.
Yeah, this shit. Need to hit the gym more. Sorry, idiot. Yeah.
Anyhow, World Global Donor Month, I think. Donate your blood.
Oh, okay. I donate plasma.
Nice. Good.
Yeah.
Good.
So we've
Solid.
gone through the first
Moving on.
principles. Okay, we've gone through the fetal maternal blood supply, the antigen versus antibody, and rhesus factor. Now we're going to go through the complications. And I'll just give you a hint. All the complications can be derived from the hemolysis of fetal red blood cells. So let's start. Can anyone think of a complication which can be caused from hemolysis of red blood cells?
Death.
Oh, fuck the death. Of course death is always a thing, but no, just...
What? No, is it not? Is it? Or
This is not a
Is that
case
the
where we're...
most fatal consequence?
This guy,
right?
you know, like when we're like listing the complications of cholecystectomy, just death, all these
Death.
surgical complications,
Go
death,
straight for it.
infection.
Or is it not-
0.5%.
Is it or is it not a potential complication?
Yes, it is.
There you go. Will I
Death
get a
of-
mark for it? Yes.
The baby or the mother or both?
I think the baby. yeah,
Okay. Okay.
because the fetal red blood cells are destroyed. But
Okay.
yes.
Anemia.
Anemia. Perfect. Yeah. Because simply
Too easy.
destruction of red blood cells equals reduction in hemoglobin. Okay. Anemia. What else?
Destruction of red blood cells would mean, I guess, an increase of all that kind of byproduct.
Yes. And what does that lead to?
Ooh.
Ooh.
A lot of babies have it when they're born.
Jaundice.
Hepatomegaly and
Jaundice.
So jaundice, yes.
So that's from the bilirubin, right?
Yep, so increase in red blood cell destruction leads to a rise in bilirubin or hyperbilirubinemia. And
Right.
it's important to note that jaundice can be pathological or physiological, and usually jaundice within 24 hours after birth is considered pathological. Whereas physiological jaundice is usually 24 hours after birth, so like a few days afterwards. And it's important to know that neonatal jaundice can be bad because it can lead to the deposition of unconjugated bilirubin in the basal ganglia, which is called connectorus or something.
Connectorus, yeah.
Connectorus, yes.
How you spell
is Bad for the baby. Kernicterus.
Oh, connectorus.
Connectorus.
Icterus is like scleral icterus.
Like scleral, yeah.
Yeah.
Anyway, bad for baby. So we've gone through anemia, jaundice. Another thing which is common with the reduction in hemoglobin.
Hypoxemia.
Yes, beautiful. Okay, and the last thing you mentioned, which often happens with jaundice, involving the organs.
Hepatomegaly.
Yeah, hepatosplenomegaly, okay? Because in regards to splenomegaly, there's increased filtering of damaged red blood cells in the spleen, and there's a compensatory increase in red blood cell production in the liver, because I think at that age, the liver produces. There is one important life-threatening complication of hemolytic disease, okay? It's called hydrops fetalis. So it's a fetal condition characterized by generalized edema and accumulation of fluid in serous cavities like pleural effusion and pericardial effusion. I don't know how it occurs, but it's just one of those.
Maybe it's like if you have less red blood cells in your blood, you have less protein, and maybe that's like less of an osmotic pool,
Yeah.
and that way you leak out.
Could be right.
Maybe.
Could be wrong.
I have no idea.
I don't know.
Yeah, it's just important to know that as a complication. And I also want you to realize too that with all these complications like anemia, hypoxia, jaundice, it's on X spectrum, okay? It kind of ranges depending how many of the red blood cells are hemolyzed, okay? So it can be like little jaundice, a lot of jaundice, or a bit in the middle, okay?
Little jaundice.
Little jaundice.
Little
okay?
jaundice for little brain.
Is there a scale for coloring?
So?
Is there a scale for color?
Yeah, well, you can use these like little measuring devices where you put on the little baby's forehead and it measures the jaundice levels, or you can use,
Oh, really?
yeah,
It's by color.
by colour, yeah.
Oh, cool.
Well, you're
Wavelengths.
going to find the hex code and then put in the logo.
I'm pretty sure, yeah, literally just use a wavelength.
Oh, that's
of
a good
light.
idea.
you find the hex code. You find the way.
So now that we've gone through the complications, we're going to go through how we prevent this from happening, okay? Because prevention is really the key to hemolytic
Anything.
disease of the newborn, okay? Not really management. We're not going to touch on that, just prevention. So how would we prevent this? What is the simple principle to prevent any disease?
First of all, you got to identify it.
Identify? Yes.
That-
and what's
that-
another, how do you identify stuff within a huge population?
A screen.
Yes,
Yeah,
you screen,
love it.
okay? Screen, okay? So whenever you do ONG, they love to do a lot of blood tests and things like that. So one of the ways you screen for possible rhesus disease is that in the booking bloods, which is usually the blood tests pregnant women do at the start of their pregnancy, they check for the blood group and red cell antibodies. So then you can find out straight away whether the mother is rhesus negative or rhesus positive. Does anyone know of another screening event within the pregnancy?
Okay, so at the booking bloods, which is usually week 8 or 10, and then you check for the ABO and rhesus blood group, and then at week 28, you also do it again, and then within 48 hours of the baby's birth, you do another one.
Yeah, but for that one, you're checking the baby's blood group.
Okay, yeah.
So now that we've done the screening, we'll move into the next step. So basically, pregnant mothers are given intramuscular injections of anti-D, which is the rhesus immunoglobulin, routinely and for suspected sensitizing events, okay? And the aim of that is to remove the fetal rhesus-positive red blood cells from the maternal circulation, which prevents an immunological response from occurring, okay?
So you don't give her the opportunity to develop these antibodies. You go in and get rid of them yourself.
Yeah. So you give them anti-D, that chews up the fetal red blood cells which are in the maternal
It's like
circulation.
an anti-vaccine.
What?
Because vaccine, you want to develop those antibodies, whereas now you don't want to do it.
Yeah, actually.
JT, yeah, anti-vaccine. Oh, man.
Don't say that to
Oh, my
anti-vaxxers, though.
Just, do you want to confuse more people? Less and less people are going to take vaccines.
So
now.
obviously the anti-D stuff, that can't cross the maternal circulation.
Just annihilate
Yeah, I was going to
the
say that.
I assume so,
that
yeah.
cannot cross
I
placental
assume so.
circulation.
Otherwise, that would be pretty illogical, right? I didn't actually check that, but
I mean, surely.
I agree.
Surely it cannot.
So, in regards to routine prophylaxis, there are certain times where you administer anti-D. Can anyone think of those times in gestation?
28.
Yeah. So 28 is one. What's another?
36.
34. So 28, 34, and the last one.
24 hours. Right after birth. I don't know.
Yeah. So within 72 hours of any birth, cesarean or vaginal. Okay? Because it's been shown that administration of the anti-D to a rhesus negative woman within 72 hours of a birth of a positive infant reduces the incidence of rhesus immune response from about 13% to 2%. Okay? So 28, 34 weeks, and within 72 hours of any birth.
Wait, sorry. So rhesus negative mums will get this anyway at 20 weeks and whenever and after birth.
Yeah.
Even if there hasn't been a sensitizing.
Yes. So they get at 28 and 34 weeks, just in case there is some event. It will make a bit more sense later on.
Okay.
I'll explain to you.
Yep.
Okay. So essentially, what a sensitizing event is an event where the fetal blood mixes with the maternal blood, allowing an immune response to occur. Okay.
Sure.
So you've got the screening, the routine prophylaxis, and now there's also another way of preventing the disease from happening is that you give anti-D within 72 hours of any suspected fetal maternal hemorrhage. So I kind of break down the fetal maternal hemorrhages into three kind of categories. You've got trauma,
Yep.
antenatal procedures, and pregnancy-related complications. So in regards to trauma, so if a pregnant woman gets into a car crash or has some type of abdominal trauma, you've got to make sure that you administer anti-D within 72 hours of that event. So in regards to antenatal procedures, we've got things like amniocentesis, which is a fancy word for sampling of the amniotic fluid.
Is that where
Yes.
it penetrates into the fluid? Yeah.
And as you can imagine,
Yeah.
risk of blood mixing,
Yes.
right?
Gotcha.
You've also got other things like chorionic villus sampling, which is sampling of the placenta to test for chromosomal abnormalities. And you've also got other procedures like termination of pregnancy, where there's potential for mixture of fetal and maternal blood.
Oh, so this is done regardless of the fetal status?
Yes.
Okay.
Because you're trying to prevent it, right?
For a future
Yeah.
pregnancy.
Yeah.
Or,
You don't
or
want to
just
take
at
a
all,
risk by
Yeah.
like waiting for the maternal antibodies.
Because
Yeah.
you have an abortion now doesn't mean you might not want to have a child
Yeah,
later on.
yeah,
So.
yeah.
Yeah, so
Yeah,
essentially
whatever.
any suspected fetal maternal hemorrhage, you want to give the anti-D within 72 hours. And in regards to pregnancy-related complications, you can have miscarriages, PV bleeding, ectopic pregnancies.
What's PV?
Oh, perivaginal
Okay.
bleeding.
Per,
Okay. Oh, perivaginal bleeding.
What does that mean? Per-vaginal?
you know, per rectum, per oral.
Oh, okay.
Yeah.
I think it's that.
Yeah, it could be that.
But
So I think
peri
it makes-
could-
Yeah, that would make sense.
yeah.
But peri could be. Oh,
As in
around
from
vagina.
versus around.
Yeah. There's also things like placental abruption.
Oh,
That's
yeah.
when the placenta separates from the wall of the uterus. Antepartum hemorrhage, which is bleed during pregnancy. and external cephalic version, where it's essentially a procedure used to turn the baby from the breech position to cephalic. Okay?
And that would cause some sort of bleeding.
Could cause.
Possibly. So anti-D within 72 hours of any suspected fetal maternal hemorrhage. And what are the three main things?
Traumatic events.
Yes.
Antenatal
Investigations.
yes. And pregnancy-related complications.
Simples, right?
Yeah, got it.
So you've got the routine prophylaxis and you've got anti-D for any suspected fetal maternal hemorrhage.
Mhm.
And the last thing I wanted to cover was another investigation you do. It's called a Kleihauer test.
Can you spell that?
Are you serious?
Spell it.
Kleihaeuer.
Perfect.
This is a maternal blood test which is used to assess the volume of fetal maternal hemorrhage and determine if additional doses of anti-D are required. Because if you can imagine, a large fetal maternal hemorrhage means that you probably need more anti-D to prevent the response from happening. Okay? So that's why you want to test for that.
Yeah.
And it's usually done at birth or postpartum. Okay? And a negative Kleihauer test indicates that only one dose of rhesus anti-D is sufficient. Okay? So Kleihauer test is just an extra thing to keep in mind.
Okay.
Okay, so quickly, can someone go over how we prevent rhesus incompatibility issues?
Let's go, Josh.
I'll have a go.
Have a stab at it.
So
So the first
step-
way, screening.
Yes.
Second way,
When do you do screening?
when do you do screening?
Yeah.
At 10 weeks.
Roughly. Yep. That's good.
Was it?
Yeah, booking bloods, yeah.
Just say booking bloods.
Booking
yeah.
bloods. Was the next one 28 weeks?
Yep.
And then at birth.
Yep.
Okay. So first one is screening. Second one is the administration of anti-D at 28, 34, and within 72 hours of birth. And then the last one is the
Special
you-
events.
You give the
special
anti-D.
events.
Yeah.
When you have one of these events being the...
What are those events called?
So when you have a sensitization
Yep.
event, which can be traumatic, procedural, or pregnancy-related complications.
Yeah.
And what's that one thing that you do if you consider the hemorrhage to be too large?
A Klein?
Kleihauer test.
Klein-Hauer test.
Kleihauer. Okay.
Easy. Simples.
Yeah. So it's simples. Okay. So the reason why I did this topic, because I reckon this is a classic like OSCE question. Okay. So now one of you get the privilege of trying to explain to me, a pregnant woman who's really concerned.
All right, Jason.
Okay?
How about we reverse this now?
Oh, no.
You're the expert.
I hate this.
Since
No.
you're the expert, all right?
Okay.
I am now the expectant mother.
Yeah.
First child, very nervous.
Yeah.
I've done my
yeah.
booking bloods. I found I'm rhesus negative, and I'm worried. You explain to me. Hello, Doctor Jason. I just had some bloods done, and it turns out I'm rhesus negative, and it turns out my baby's going to die. What's going on?
So what's going on is that you found out that you're rhesus negative, which means that you have the possibility of developing a disease called Haemolytic Disease of the fetus and newborn. I understand that's a long name and it can be scary. It can have a range of complications such as anemia, hypoxia, and things like jaundice for your baby. Okay? I know a lot of these words are scary, but we can prevent these complications from occurring through our screening programs. So you've done a great job already by getting your booking bloods done so that we know that you're rhesus negative. Okay, but we'll also check whether you've developed any antibodies at 28 weeks. And we'll also check your baby's blood group at birth to screen for this disease. And to prevent you from possibly developing the antibodies, we'll give you anti-D, which helps prevent the antibodies from developing at 28 weeks gestation, as well as 34 weeks and within 72 hours of any birth. And that helps to prevent this disease from occurring. Lastly, it's really important that you come to emergency anytime you have any vaginal bleeding or any trauma to your abdomen, as this can lead to the development of antibodies which can attack your baby. So it's important that you come in so that we can give you this anti-D, which will help prevent that from happening. So whilst I know it's a scary time, there's nothing to be worried about at this point, okay? We'll make sure that we prevent this disease from occurring through regular screening and making sure you come into the hospital within 72 hours of any birth. Do you have any questions?
So many questions, Doctor. But thank you so much for easing my concerns.
Oh,
Nice.
amazing.
Love it. Amazing. Let's give Jason a round of applause.
Yeah, woo!
Thank you,
The
Dr.
cherry on
Jason.
top.
Yeah.
I'd be worried if I presented this topic and wasn't able to explain it. It'd be really concerning for me. Anyway, the 3 key takeaways I wanted you guys to learn was that normally maternal and fetal blood do not mix during pregnancy. The main complications of haemolytic disease of the fetus and newborn can be derived from hemolysis of fetal red blood cells, for example, anemia and jaundice. And prevention of this disease is achieved by screening of rhesus-negative women with early blood tests, routine prophylaxis with anti-D administration at 28 weeks, 34 weeks and birth, and lastly, anti-D within 72 hours of any suspected fetal maternal hemorrhage. Those are the 3 key takeaways.
Very sexy.
Beautiful. Awesome.
Thank you, everyone, for tuning in. Please hit us up, comment on the notion. And the notion has been reviewed by Professor Paul McGurgan this time. So please take a look, check out our Ankies, and we'll see you next time at 1 p.m.
Hello, everyone. I'm Josh. Let me just say some more words while I think about your question.
Thanks so much, guys, for listening to this week's episode of 1pm. If you want some more resources, please check out our Anki flashcards or our Notion documents, where you can find some links to other episodes. Thank you.